Ok. Márcio, no seu sinal, podemos, Márcio?
Sim,
Acho que
tudo
já está.
certo.
Tá ótimo. Podemos, Mauro?
Podemos.
Então, tá bom. So, good afternoon to everyone. We're here for a new edition of the Immuno webinars. Today, we have Professor Mauro Teixeira. It's kind of hard to introduce Mauro. His CV is too long for a short introduction, but I'll be try to be very brief here to introduce him. He's a professor at UFMG. He's member of the Brazilian Academy of Sciences, the World Academy of Sciences. He's a coordinator or director of a big ENCT initiative on dengue and other host microorganism interactions, and publishes a lot, right, Mauro? And I think he's going to do us a lot well to talk about the drugs that may be used, right, to resolve inflammation and cure many of the diseases we have. So, Mauro, thank you very much for accepting our invitation, and the floor is yours.
Thank you, Thiago. Just give me an okay if you can hear me well.
Yeah, it's okay.
Okay, thank you. So it's a pleasure to be here. Thank you on the Immuno webinars for the invitation. So I will try to talk in the next few minutes about resolution of inflammation and how we think it is useful for, it may be used for the treatment of infectious disease. Before we move, just to remind you that next year with ICB and ISBIN, the Societies of Inflammation and Immunology, we are organizing the World Congress of Inflammation, which will take place at Foz do Iguaçu from September 8 to 12. So I do hope everyone can join us. So a little bit of background. We are now what we call Centers of Innovation and Technology of UFMG. So the idea of these centers is to approach basic research into clinical development. So our CT, Center of Therapy, Center of Technology, Advanced and Innovative Therapies, is composed of three major centers or labs. One which is at ICB here at UFMG, that we do all our basic research. We also have a very large clinical research unit in one of the health centers in Belo Horizonte, and we are constructing this intermediate GLP lab where we can actually move from basic research to clinical research. Just to have an overview, at our clinical research unit, we have been doing a lot of different research studies from drug trials, vaccine, and community trials, most of which are focused on infection, and most of which are focused on the arboviral infections, obviously because the INCT dengue has helped a lot in the creation of these centers. As part of our Center of Therapy, Center for Technology in Novel Therapies, we also do have a lot of work on nucleic acid delivery, especially via lipid nanoparticles. This is mostly work by Pedro, who is an associate professor. And Thiago, I strongly advise you to invite him because he will give a very good talk to this audience, I think. So Pedro works a lot on these lipid nanoparticles, and we are doing actually work on trying to use this as delivery for new vaccines, CAR T cell development, and cellular reprogramming, both in vitro and in vivo. Obviously, I'm going to focus on what I do most, which is to do with innovative therapies, and of these, on the role of mediators of resolution in treating disease. And I think this is a slide that actually summarizes a lot of what I have to tell you. Under normal conditions, we have an inflammatory stimulation that tends to resolve and reach homeostasis again. Even if this homeostatic stage is a little bit different from the beginning, overall, in most conditions, we do reach homeostasis after an inflammatory stimulation. Under chronic inflammation and severe infection, we have this failure to resolve inflammation. And failure to resolve actually contributes to inflammation, to the severity of chronic inflammation and to chronicity itself, but also contributes to disease in the context of infection. So what we are proposing is pretty much, can we actually give mediators of resolution back and try to resolve something that has failed? And this has been dubbed resolution pharmacology or induced resolution. And it's a novel way to treat inflammation and treat infection. And it's very therapeutic from the outset. It's a concept that's based on therapy, not prevention, but actually something that's wrong or going wrong and that you treat to normalize. We actually reached this studying human microbial interactions. And I'll give you some numbers and trying to tell you how important or why we think inflammation actually contributes to disease associated with infection. So there are about 10 to the 12 microbial species on Earth, the vast majority of which are outside. We never interact. We don't have the molecular counterparts. About 300 to 500 species of bacteria will live inside our gut. So these are parts of what I think physiology of the immune system. These bacteria are very relevant for the setting of the immune response and also help us dealing with the foods we take every day. So we do interact a lot. And life, as I say, life of a human is about interactions. As I said, most of the interactions do not exist because we don't have molecular counterparts. Some of it has to do with our resident microbiota in different parts of our body. And I suppose these resident microbiota is what I call healthy interactions and contributes to the physiology of the immune system. But a few of the things that we interact with will infect us, will eventually cause disease and eventually death. So although this is the tip of the iceberg, they are very relevant because it kills us, obviously, and it takes us to the doctor and prevents us from doing whatever we want with our life, including work. And these pathogens, let's say, or not necessarily pathogens, but microbial species that will cause disease are about 10 to the 3 in terms of scale. So there are currently about 1,100 bacterial pathogens that are known to infect us, and the criteria here is at least a bacterial pathogen that infected at least 3 people. If you go further and explode that, there are about 1,400 species of human pathogens, including virus, bacteria, fungi, protozoa, and helminth. So you can see the scale of the interactions we have. So from the 10 to the 12 trillion microbial species on Earth, about 10 to the 3 are actually capable of somehow establishing an infection and infecting us. So our immune system is not bad, right? 10 to the 3 to the 12. Obviously, a lot of it has to do with non-interaction, but we know we are able to keep things at bay outside us. How does that happen? And so in practical terms, as we interact with a potential pathogen, we may simply not interact, but if there is an interaction, there may be infection, which pretty much correlates with the capacity of this pathogen to multiply within our body. If this infection causes release of mediators of inflammation or causes symptomatic infection, there will be disease. So there is a very important difference here from infection and disease. Disease has to do with clinical presentation of infection, right? And I'm not even talking about severity of disease. So one may be infected and not ill. One may be infected and with disease, severe disease, and even death. As we interact with these microorganisms, there will be the release of mediators of inflammation. These mediators of inflammation will cause an acute inflammatory response. This is necessary to contain infection at a certain organ or part of the body, and will also be necessary to instruct the adaptive immunity. And together, the initial inflammatory response and the adaptive immune response will control infection, and that will be returned to baseline. And that actually happens the great majority of times that we keep microorganisms outside, and if they infect us, they don't cause any harm. However, we do know, and we know this is relevant. If you don't have an immune system, as one with HIV, cancer treatment, there will be an upsurge of disease upon infection because you simply cannot mount either the acute response that contains infection or instruct your adaptive immune system. And if you're under cancer treatment, you may not even have an adaptive immune system. Now, we are interested in disease because this is what takes people to hospital, and that's what kills people. So when does disease occur? And I will try to make you, to show you what we think it will occur. What I think it's the reason for disease to occur. Is actually when the acute inflammatory response or a malformed adaptive immunity doesn't occur properly, you may have disease. And our hypothesis is that disease results from this inadequate. Inadequate is a good word because it doesn't mean much. You can, go for whatever way you want, and it can mean several things, from insufficient, as in HIV or neutropenic individuals, excessive, such as in sepsis, misplaced. Sepsis is also a good example where you have inflammation in the bloodstream, not in tissues, or altered, in which you have different mediators of inflammation. So disease will occur when these mediators are such that they don't drive protection, but they drive pathology. They drive changes in the host that will be associated with disease. So we do need that inflammatory response to control and contain infection. However, if this is altered in such way that you don't contain the parasite or the microorganism, but you actually change the physiology of your organ, that may come out clinically as a disease. So you can hypothesize whether you find host molecules that are produced during infection that cause disease, but actually are not necessary to induce protective immunity. So the idea is, as your body is responding to infection, you will have the production of mediators of inflammation, many of which are necessary to control infection, but many of which are not, and may actually drive disease, and we are trying to separate these. This is something that we've been working for many years. This is, for example, reviewed in 2010, and the idea is that the inflammatory response itself can cause tissue damage, and that may present clinically as disease. And we are really trying to understand, these mechanisms or how that differs from adaptive immunity and adequate immunity. For example, you can show that experimentally in a model of dengue infection. In this model of dengue infection, there is thrombocytopenia as you infect mouse. Thrombocytopenia is accompanied by plasma extravasation. And actually, plasma extravasation is much, much more relevant than thrombocytopenia. Many people talk about dengue and thrombocytopenia, but thrombocytopenia does not necessarily drive disease. It's a marker of disease, but it occurs in other infections, and severity is really given by plasma extravasation. If plasma extravasates, there is a decrease in the amount of fluid you have in your intravascularly, and that leads to fall in blood pressure. Now, if we treat with a PARP receptor antagonist, or we do experiment in PARP receptor deficient mice, you see that thrombocytopenia is greatly prevented. Evans blue dye extravasation is decreased. This is at day 3. And because you don't have plasma extravasation, your blood pressure goes back to normal. And now you do that and you protect the animals partially from death, but you also delay death in these animals. And you do that without changing the ability of the host to deal with infection. So what we are saying here is that you have a mediator, which is PAF, platelet activating factor, that drives disease, thrombocytopenia, plasma extravasation, and hypertension, but it's not needed to control infection. Now, so I think I presented that. This is also a reasonably old study, is to say that now there is quite a lot of clinical evidence, preclinical evidence, to suggest blocking inflammation is useful as an adjunct treatment of infectious disease. And obviously, COVID brought that very strongly to us, because for the first time, we have now very strong clinical evidence that preventing inflammation is associated with better outcome of an infection. So indeed, in COVID, you give anti-IL-6, not 16, steroids, kinase inhibitors, you have a better outcome than, in severe patients. Now, our question was, a few years ago, can we use the logic of the mediators of resolution? Can we use the logic of resolution of inflammation to prevent disease? Because these are very strong anti-inflammatory, anti-disease molecules. So can we use mediators of resolution to prevent disease, but still maintain adequate protective immunity? So what is resolution of inflammation? Just going back a little bit. So under normal circumstances, if we have an infection, a cut, a bruise, there will be the release of pro-inflammatory mediators, which will drive the influx of cells. And that influx of cells is what I said needed to control infection, to cure a cut, and that will lead to homeostasis. Now, and this is the process we use to treat inflammation. We give things that prevent the arrival of cells, anti-TNF, chemokine inhibitor antagonists, etc. Now, the concept of resolution is a bit further down. What was found is, that process of going back to normal is not passive. It has to do with the production of a large amount of mediators, or which we call pro-resolving anti-inflammatory mediators. I like pro-resolving molecules. And the production of these mediators will initiate a series of processes in cells, including the death of apoptosis, by apoptosis of granulocytes. The dead cells will be engulfed by macrophages, which is called efferocytosis. So the same molecules that kill neutrophils bring in monocytes that will engulf these cells, efferocytosis, and that will reprogram these monocytes, macrophages, into a phenotype that facilitates the cleaning of the tissue and the homeostasis itself. But I think the major message here is that mediators of resolution are absolutely necessary for the resolution of inflammation, because this is an active process. You need to produce them. It's not a passive process. Okay, so what are the mediators of resolution? This is pretty old, but it hasn't changed in character. So we have lipid mediators, and these were the first ones described by Charles Serum a few years ago. And he usually refers to them as SPMs, specialized pro-resolving molecules. But the term SPMs only refers to the lipids, not to the others. There are proteins, there are peptide, gases, and other molecules such as short-chain fatty acids, hydrogen peroxide. So the range of molecules which are actually capable of resolving inflammation is quite marked. And so what defines a pro-resolving molecule? So it will have anti-inflammatory activity because it prevents the infiltration of neutrophils, eosinophils, granulocytes in general. It will kill them by apoptosis. So if you give a pro-resolving molecule to a neutrophil, it will kill it by apoptosis. It will bring macrophages in. As macrophages come in, they will engulf this dying cells, apoptotic cells. This is called efferocytosis. And the process of seeing the pro-resolving mediators and engulfing dead cells will modulate macrophage function in such way that you have these anti-inflammatory pro-resolving phenotypes. So the production of pro-resolving mediators will tip the balance of the tissue towards this pro-homeostatic anti-inflammatory phenotype. Okay, I will describe a molecule which we've worked a lot in the last few years, angiotensin 127. Angiotensin 127 is derived from angiotensinogen. Specifically, it's derived from angiotensin 2 as it's cleaved by ACE2. So ACE2 is also by chance, I suppose, or not, the receptor for SARS-CoV-2, but it was much before that. So these studies from this review from 2013. So ACE2 will cleave angiotensin 2 into angiotensin 127, and this 7 amino acid peptide will bind to a receptor called MAS. It's a 7-TM transmembrane receptor, and overall, the activity of this receptor will drive anti-inflammatory, anti-remodeling, and anti-proliferative activities. So I think we were among the first to identify that angiotensin 127 is anti-inflammatory. This is in a model of arthritis in mice. So if we give angiotensin 127 or a mimetic at the MAS receptor, you have a dose-dependent inhibition of neutrophil influx. That's counting NPO, that's counting neutrophils in the joint, and this is associated with inhibition of pain. Now, as all anti-inflammatory strategies, you tend to give before the inciting stimulation. So this is a model of antigen-induced arthritis. You give the antigen here, you're giving your anti-inflammatory strategy before the antigen stimulation. Now, for the pro-resolving molecules, you give it after. So you give the antigen, wait for the cells to arrive, and then you treat. And what you hope is by giving your pro-resolving molecules, you induce resolution of inflammation. So we immunize animals, give the antigen, and treat at the peak of inflammatory response, which is about 12 hours in this model, and look 24 hours later. So we treat here, neutrophils are here. So these are the number of control neutrophils. If you give angiotensin 127, you make things go back to normal in a much faster way. You resolve inflammation because you're killing the neutrophils via apoptosis, and this is caspase dependent using this strong-specific caspase inhibitor. Okay, in vitro, you can treat neutrophils with angiotensin 127 that will induce apoptosis of neutrophils, and this is receptor dependent, MAS receptor dependent, because it's blocked by an antagonist at the MAS receptors. Okay. I also told you that pro-resolving molecules bring neutrophils in, monocytes, macrophages in a non-phlogistic manner, meaning cells arrive and there is no pain, there is no fever, there's no change in function. So clearly, you can inject angiotensin 127 in the cavity of mice, for example, or in the cavity of mice in the right-hand side, or using raw cells or BDMEMs in vitro. And angiotensin 127 will make monocyte macrophage migrate similarly to CCL2, which is a very well-known activator of this process. So angiotensin 127 will bring these macrophages in. The phenotype of these macrophages, once they arrive and phagocytose, it tends to go to an MRAS M2 phenotype. This is not by molecular sequencing, it's just by phenotyping. So it's just an indication that these are M2 MRAS phenotype. And clearly, these macrophages, they are at the same time capable of eating dead cells, phagocytosis, but also because they can eat dead cells, they can eat bacteria. And I think this is really interesting. The process that makes them cells, by activating them with pro-resolving molecules. At the same time, they are able to clean the tissue and eat cells. They are capable to deal with bacteria much, much better. So they internalize bacteria or dying leukocytes in a much better way. So I've shown you for angiotensin 127 that it prevents inflammation. It induces PMN apoptosis. It brings macrophages in and makes them eat more and changes their phenotype. So can we use this concept now? And I will use angiotensin 127 to prevent disease but maintain adequate immunity, right? So this is a study in a model of influenza virus in mice. And again, here's the concept. I'm giving angiotensin 127 after the treatment. So I infect mice with influenza and treat from days 3 to 10 and wait to see what happens. And what we see is that angiotensin 127, as expected, decreases a lot the inflammation in tissue, as seen by looking at lung histopathology or by counting neutrophils, which migrated into the BAL. And why does it decrease neutrophil numbers? Because it actually makes them, it kills them by apoptosis, and it makes the macrophages eat them. So when you give angiotensin 127, what you see is that you enhance apoptotic phenotypes in neutrophils, and the apoptotic neutrophils are eaten by these macrophages, which have seen angiotensin 127. And interestingly, it does have some antiviral activity, which is not direct. You know, influenza needs a lot of signals from the host to proliferate, to replicate adequately. And as you give this anti-inflammatory drug, it does decrease anti-inflammatory signals necessary for influenza viral replication. Now, because you decrease inflammation, because you decrease the number of neutrophils, it prevents death in these animals with severe influenza. So in this model, about 50% of these animals are dead after influenza infection. You give angiotensin 127, we see about 80% in this system. Just to show you that angiotensin 127 will also do that in models of beta coronavirus infection. It will decrease inflammation, seen by lung histopathological score, the amount of protein plasma extravasation. And by decreasing the inflammation, it will prevent the dysfunction associated with inflammation. So angiotensin 127 decreases cells. The lung function is much better with angiotensin 127. And because the animals are better, they tend to survive an inflammatory stimulation. In this case, infection with a beta coronavirus in mice. Now, and this is a bit more complex study. You know, one can use influenza at a high inocular and it will kill the animals. Also, one can use streptococcal infection at high inocular that will cause severe pneumonia. But you can also associate these two things, and this is seen clinically a lot. So if you go back to the 1917 or the epidemic of influenza in the First World War, most people actually died not of influenza itself, but of pulmonary infection that followed influenza. At the time, there were no antibiotics. Once you do that, we can model that. So we give a low dose of influenza that doesn't kill, and we add a high dose, a low inoculum of streptococcus, and that will actually cause a disease that is similar to this high inoculum. I'll show you this. So in green, that's low dose of influenza. It will cause disease, but animals get better. In blue, a low dose of streptococcus. The animals will suffer a little bit, but they get better. Now, if I give this low inoculum of influenza, of streptococcus after influenza at day 14 or 10 to 21, you have a very severe disease that is associated with changes in macrophage function mostly. Okay. Now, what we did here is treating during influenza and then infecting. So I treat from day 3 and 10 and then infect with streptococcus at day 14. So the animals only saw angiotensin during the influenza infection. But what we see here is that this early administration of angiotensin 127 prevents the subsequent S pneumonia infection. So you're actually able to change the environment, to change the macrophage phenotype in the lung in such a way that you change the capacity to change this. So we are trying to investigate this in a bit more detail. We have done this for other molecules, and it's to do with reprogramming of the macrophages. So far what I've shown you is that during viral infection, there's decreased severity of disease. In some models, there is decrease in viral load, but never an increase in viral load. Decreased severity is because you decrease neutrophil influx and pulmonary damage. Because there is less pulmonary damage, the lungs are better, lung function is better, survival is better. And there is also macrophage reprogramming. Okay, can we see similar things with bacteria? And bacteria is interesting because it relies much more on neutrophils to clear infection. And we have a very similar phenotype, only the models are much quicker, right? We don't have a very large window as we have for the viral infection. So you really have to start treatment at 12 hours, 3 doses only, you give every 12 hours, and you do euthanasia at 48 hours. And by doing that, what we see is that treating with angiotensin-127 will markedly decrease the amount of neutrophils. So we were really worried with this because you're decreasing so much neutrophils. Are you still able to deal with infection? So angiotensin-127 will decrease the amount of neutrophils, but it also decreases damage as measured by protein extravasation to BAL. If you look in the lungs, the situation with the lungs is much better. Not only the neutrophils, but also edema, pulmonary epithelial damage, and everything else. So overall, what we see is that treatment with angiotensin in this system will make the whole infection by Streptococcus look much, much better. So how does it do that? Because, first, because your lung is better, your lung function is better, your inflammatory response is better, right? You see a much better survival rate. So whereas all animals die within, mostly within the first 4 days of infection, treated animals, treated early will survive about 50%. And what was really surprising is that, not surprised, very marked, is that angiotensin-127 will decrease very significantly, about 3 logs, the amount of bacteria in the lung. And because you decrease so much the amount of bacteria in the lung, they don't become systemic. It becomes contained in the lung. So basically, what angiotensin-127 is containing infection in the lung, preventing systematization of infection, and animals do survive a lot. Now, how does it do that mechanistically? So first of all, why does it decrease the number of bacteria? Simply because the macrophages, which see angiotensin-127, internalize and kill bacteria much better. Not only you have a better ability to deal with infection, but you also increase a lot genes associated with epithelial barrier function. So in the presence of angiotensin-127, you decrease the number of bacteria in blood because your macrophages are capable of dealing better and enhance the epithelial barrier function of your epithelium, of the lung epithelium. Now, and I will drive you through this. I showed you that if you give angiotensin-127 early, you have a partial protection. So black is vehicle. This is partial protection when you give angiotensin-127 very early. If I delay angiotensin-127, you see no protection, right? Because as I told you, most animals are dead by day 4. If you delay to 60 hours, 2.5 days, you see very little. If you give antibiotics also at 60 hours, you see some protection, but not as marked. Now, if you combined antibiotic with your angiotensin, you see a very, very significant protection from that. So basically what we're saying is you allow time for your antibiotic to work and by preventing that excessive early inflammatory response. This is also similar with a completely different model. This is now a gram-negative bacteria, Pseudomonas aeruginosa, and also we give you angiotensin. This is a slightly longer model. If you give antibiotics early, protection. If you delay antibiotics 24 hours only, no protection. Angiotensin 127, 24 hours, no protection. Now, if you're giving angiotensin 127 plus antibiotics at a late stage, which we're here, you see a complete protection. So you are allowing the host to deal with infection in a much better way when you're combining these two things. And why does it do that? It's same thing here. So basically, by giving angiotensin 127, your macrophages are much better able to internalize bacteria as measured by the number of bacteria or the percentage of macrophages with internalized bacteria. And this is mirrored by a very significant decrease in the number of viable bacteria in the lung. So you are able to make macrophages better capable of eating and killing bacteria if they see angiotensin 127. So what I've shown you is that gram-negative or positive bacteria, you have a very much decreased severity when you treat with pro-resolving molecules. And these beneficial effects are associated with decreased accumulation and activation of leukocytes, haven't shown any activation, with decreased bacterial load, because there is enhanced phagocytosis and killing of bacteria, enhanced epithelial barrier properties, and synergism with antibiotics. And just to make the point, I've shown you only bacterial, lung, or viral infection, but the pro-resolving strategies also protect from severe disease caused by other infections. So it's not only about the lung, it's not only about the angiotensin 127. It seems to be a class effect. So in this paper, we showed that annexin-1, which is another pro-resolving molecule, protects against dengue. If we use different molecules, cysteine-marazines, lipoxygenase 4, short-chain fatty acids, what we see is that overall, the treatment of mice with pro-resolving strategies make greatly enhance your ability to deal with viral and bacterial pneumonia and also diseases outside the lung. Now, I think these are the three main points which I want to show you, is that resolution pharmacology is a useful strategy to mitigate disease and death during bacterial and viral infections. The beneficial effects are additive to those of antimicrobial agents. And this is why we say that, these molecules, anti-inflammatory molecules, should always be given with antimicrobial, antiviral compounds, because they do enhance their activity. And on the other hand, and I'm thinking of the difficulty we have with antibacterial drugs overall, it may be that these agents will prolong the life of certain antimicrobial, antibacterial compounds as well. The beneficial effects appear to be a class effect, not only one, but various pro-resolving molecules, and applicable to various infections. Indeed, you're not giving a particular antibiotic with a certain mechanism of action. You are approaching the host and hoping that by changing host function, you will make the host better able to deal with various infections. I think we do need to understand the mechanism by which these molecules are capable of enhancing phagocytosis and killing, because at the same time you're enhancing phagocytosis, you're not enhancing inflammation, and most things that enhance phagocytosis enhance inflammation. So there is a divide there that we need to understand a little bit better. And also, as a clinician, how to move this forward into humans. So which are the molecules? How to do that? I'll show you results with one clinical candidate. The molecule which I'm showing here is called AP1189 or resomelagon. This molecule is a receptor agonist at melanocortin receptor 1 and 3, so MCR 1 and 3, so receptor for melanocortin hormone. It binds to these receptors and it activates certain activities such as PR, for example, but it does not increase cyclic AMP levels. This is interesting because cyclic AMP is quite an interesting anti-inflammatory molecule, But if you go to epithelial cells, melanin expressed epithelial cells, if you enhance cyclic AMP, you will change color. So anyone taking this melanocortin will be darker. So that may be an unwanted side effect because the color is not like tanning. It goes to more brownish. It resembles other drugs that do that. So AP-1189 will keep its anti-inflammatory effect without actually activating epithelial cells that express melanin. And so we did a lot of experiments with this drug in models of COVID, influenza, and it certainly has a lot of clinical activity, preclinical activity. It will decrease, for example, inflammation caused by beta coronavirus in mice. It will decrease inflammatory production of pro-inflammatory cytokines when you infect with this beta coronavirus or SARS-CoV-2 indeed. Now, because AP-1189 was being developed, was undergoing phase 2 for human rheumatoid arthritis, we got in contact with the company and did a clinical study in patients with COVID. So this is a double-blind, randomized, placebo-controlled trial, which asks whether AP-1189 will reduce the time to respiratory recovery. So what does that mean? So we are recruiting patients with COVID that need oxygen. So I asked the question, how long does it take for this patient to remove oxygen in the presence of placebo or AP-1189? And everybody was using steroids at the time. So does AP-1189 increase or actually decrease time to respiratory recovery? So on average, people recover, on median actually, it's a median, about 6 days after arriving in hospital, and they are discharged about day 10, day 11 after respiratory discharge. So it takes about, on median, 4 days from getting better and then going back home. If you give AP-1189, your time for respiratory recovery is only 4 days, so 30% less. And because you're better earlier, you go home earlier. And at the time this study was conducted, we could not do severity in terms of whether it prevented death or anything like that. But clearly, just by decreasing a day in hospital stay, that means you save about 20% of hospital beds in the context of a very severe epidemic. So this drug significantly reduced time to respiratory recovery. Because it did that, it reduced time to discharge. Overall, all of the complications associated with COVID, time for ventilation, acute kidney injury were decreased, but the study is too small to see any significant effect. And there was no major treatment associated adverse event that would prevent administration of AP-1189. I think the importance of this study is actually to be the first demonstration in humans that you can use a pro-resolving strategy to treat infection. I think I will leave you that this study shows that, and our view of the future is that we believe that residual pharmacology in general will be used in most human infections in the future because it does change your your prognosis. It tends to allow you to have a better prognosis and prevent disease and severe disease induction. With that, I thank my collaborators, Vanessa, Landa, Vivian, and Dani, who actually themselves have they are associate professors. Actually, most of them are full professors now in our institution. The clinical studies was done by my master degree student, Pedro, with the collaboration of Mauro and Thomas. And this is our work at CT Terapias. Funding is interesting to see that the NIH is rapidly moving away from being a relevant funder, but still one of our studies is funded by the NIH. But we are extremely grateful for this National Institute in Science Technology funding that made a huge difference to our work. So I'm grateful to that as well. Thank you for your attention. And I leave this also reminder of the meeting we'll have next year as part of the immunology and inflammation meetings. Thank you very much. Happy to take any question.
Thank you very much, Mauro, for a very powerful talk, very, very interesting results. I think we'll have a lot of questions. Yeah, I see hands raised in Rio. Do you want to talk, Bruno? Do you have questions from students?
Yes, we do have a question from a student here.
Professor Mauro, thanks for presentation. My question is, how do you see the administration of cannabinoids in resolution phases and your use in clinical future?
So I'll start with it. I think it will be extremely difficult to develop cannabinoids clinically. It's simply difficult. You know, so I was at Anvisa, you know, at CCVisa, Scientific Committee for Anvisa, at the time we started discussing cannabinoid. And the decision Anvisa, FDA, Canadian did in relation to anything related to cannabis is we don't regulate. If you don't regulate, it's difficult to do clinical studies in a proper way. So I think unless we have a drug that you call something else and don't say cannabinoid, for God's sake, I'm not saying it's not a good field. I just say it's extremely difficult to move forward as a drug, right? We have done a few experiments with PEA, I think, which I never know, it's a huge name. And it does have, under certain occasions, a pro-resolving activity. But as I said, it's extremely difficult to move clinically. So just keep that in mind. One thing is the effect of a cannabinoid, the other is to move it forward clinically. Because, you know, I don't think the people are selling cannabinoid. So there is a panacea here. People are selling cannabinoid too much without proof. And when you have to do this study, you cannot get funding. The companies are not interested. So it's complicated.
Okay,
you know, it's the thing. I chose not to study this.
Okay, thanks.
Okay, we have questions from Miriam at ICB also.
We have another question here, but we can wait.
Oh. Okay.
Oh, so sure. Go ahead.
I want to say my thanks as well. And I didn't really have a question until my colleague there also made a question. Because this is really interesting to me. That you said that it's very difficult now to do research in cannabinoids. And I want to ask you a little bit more about it. Do you think it's more regards of the lack of funding, or it's more something that, I don't know, maybe society is just not ready to see it as a good alternative for future research?
No, I think, I'm not saying for preclinical work, I think there's still funding. It's just that, you know, it's a societal thing. It's nothing to do with the science at all. It's just hard to discuss. You go to all the Congress, not only ours, everywhere in the world. You know, if you want to discuss that, other people will have a lot of saying. So regulatory agencies everywhere in the world, they chose not to regulate cannabis research. And that creates a problem, which is, if I don't regulate, who does? Who is responsible for this research? And if I don't regulate, how do I apply to an agency? How do I sell it? So it's just complicated. It's nothing to do with the quality of the research, you know, the basic research, the rationale. It's just regulatory. It's a regulatory process. It's a regulatory problem everywhere. So you have somehow to dissociate. It's a drug that acts on CB1. People don't even know what CB1 or CB2 is, right? It should just, you know, at the same time, other people are using the argument that cannabinoids are good for everything. So people who sell it, they say that and don't show it. I think if we want to make a drug developing in a rational and, you know, I'm missing the word here, in a responsible way, we do need to do clinical trials, placebo-controlled, randomized, double-blind, and this is simply difficult for the field because there are people who do believe that it works and people who do not want it to work. And this is nothing to do with the science, it's regulatory.
Thank you.
Okay, at Sao Paulo, do you guys have questions from students?
Yeah, hi Mauro. Thanks for your great lecture. We do have a couple of questions from students here.
Hi, thank you for the lecture. I was thinking about the vascular system when you say that you give to the animals Angi-17. So did you check any vascular measures, so blood pressure or vascular contraction or dilation? So, and do you think that this is an important thing to analyze in this case because you have good data with this peptide?
Yeah, and obviously it's called angiotensin, right?
Yes, angiotensin.
You know,
It's a vasodilation.
yeah, but it's a terrible name. You know, it's almost like cannabinoids. It doesn't have very much effect on the blood. And for, you know, it tends to on endothelial cells, it will release nitric oxide. It will dilate a little bit, but it's the vascular effects of angiotensin are very small. And that actually delayed development of angiotensin 1-7 as a therapy for many years. Because, you know, when it was discovered, it was purported, it was sold as, I want, you know, it was an antagonist of angiotensin 1 to angiotensin 2 effects. But it is not. It is a terrible antihypertensive drug. It doesn't decrease hypertension. You can give a ton to an animal, it doesn't decrease blood pressure. So it can have an effect on blood pressure, okay? But it is very small and it doesn't seem to account for most of the effects we've seen. But, you know, and even the name brings that, right? You know.
Hey, Professor Mauro, thank you for the talk. And still going the same direction of the last question. My question is regarding that people that take some medicines that act directly on this inhibitors of the angiotensin conversion, right? Like captopril. So it is there is any literature showing that these patients, they are more susceptible to infections, or at least they have more neutrophils circulating.
Yeah, but you know, captopril is complicated. It's a terrible drug. You know, I 3 times a day. But you can talk about the AT1 antagonist. You know, the receptors for angiotensin 2. I think overall, to be honest, I think there is more evidence that they are inhibitors, especially for chronic diseases, that they are pro-inflammatory. And what happens is, for whatever mechanism of regulation, you increase ECA2 instead of ECA1. You tend to have more angiotensin 1-7 when you give ECA1 inhibitors, right? You shift the balance towards the other way. So, and for many years, people actually believe that, and this is there was the rationale before, you know, a lot of the effects of ECA1 inhibitors is to do with increase in angiotensin 1-7, but that is not the case for hypertension, right? We have experiments, not with ECA inhibitors, but the angiotensin antagonists, that it depends on the model, especially if you go to the kidney. Anti-inflammatory effects of AT1 antagonists are due to increase in angiotensin 1-7 and production and activation of the MAS receptor. So I think there's a crosstalk between the two systems. It is relevant in the inflammatory, but it goes the opposite of what you're saying. in general, but it doesn't account for the antihypertensive effects. See, I don't even say hypotensive, antihypertensive effects. Yeah.
Okay. Any other questions in São Paulo or Rio?
I have
from
one more
students?
question.
Yes,
I have one more
please.
question. Nice talk, Professor. Really nice data. And in beginning of your lecture, you say about sepsis, like acute inflammation, systemic inflammation. And I have a question: if your angiotensin 1 and 7 have improved outcomes in the septic mice, or did you know about it?
Yeah, just to pneumonia caused by pneumococcal pneumonia is a model of sepsis. Don't think of sepsis only from the abdomen. You know, sepsis is inflammation and bacteria in blood. So as I showed you, there's bacteria in blood. Okay. Now, because we associate a lot sepsis with CLP models, it is a good model of sepsis, but it's not the only model of sepsis. You can have sepsis from bacteria, from the lung, skin, whatever. We do see effects with models of CLP, which is similar. So I didn't show because it's boring. It's just another model way. So yeah, but we do see an effect, and the effects are similar. Decrease neutrophils, prevent, you know, bacteria from going systemic. But this is a bit circular. If you allow the inflammation to contain the bacteria in the gut or in the abdomen, you will have less sepsis. You will prevent bacteria from reaching the circulation, from causing, you know, the inflammatory syndrome associated with sepsis.
Okay, we have questions from Rio, Hayes Ransver, from Maria Bello, from Miriam, Bruno.
I don't think Bruno heard.
Bruno?
Well,
Did I-
actually, in line, Miriam is first, and then Maria Bello.
Hi, Mauro. Thank you again for accepting the invitation and giving a talk to us. It's really, really nice to hear your work. So one of my questions has already been asked and answered. So I'm just gonna ask for a curiosity. Do you know if you treat mice that are with a reasonable infection, let's say that it wouldn't be life-threatening, but if you treat with angiotensin 1 to 7, do you get a worse, like, would there be something against medicating the patient as soon as he arrives to the ER, let's say, with that to check if it would be needed or not? Or you would have to fulfill some parameters to be able to be eligible for treatment?
Right. So, Amelia, this is a very relevant question because, you know, the advantage of mice is that you know the time of everything, right? I infected at 8 o'clock in the morning, and I come along. And when you see patients, you know, you never know when infection started. You know when symptoms started. And even though you know a little bit, right? It's a 12 plus or minus 12 hours. Because, you know, if you ask someone, when did you start fever? They will say, I measured 8 o'clock at night, but you're probably starting with a body ache, you know, calafrio. I have no idea how to say calafrio.
I think that's shivers. Shivers? Yeah.
Yeah. Shivers, you know, a few hours before, and this is associated with the fever. So it's hard to time. So overall, in experimental systems, you don't see a problem with giving the drug to mild infection. You never make it worse, right? But the timing can be, in some models, timing is a problem, not the severity. So it always protects if you give late. If you give too early, you may prevent the neutrophils from arriving. So you don't want to give too early. That may be a problem. To be honest, we only saw that in a model of I don't remember, dengue maybe, that if you give too early, not influenza, not pneumonia, the bacteria are better off in general because you activate the macrophages. So that is the only thing. So it never makes mild infection worse, but timing may be an issue, and it will be an issue as we move into the clinic. Yeah.
Okay, thank you.
Maria.
Hello, Mauro. Thank you very much. Very nice talk, as always. I'm an adaptive immunology person, so of course I'm going to ask you about the acquired response because it is modulated by the initial inflammatory response. So, so have you looked how this treatment could affect the adaptive immunity? And I understand that memory is not an important thing when you're trying to save the life of somebody who is anyway, I think is an important thing to think about. So I would like to have your comments on it.
Maria, when you're dealing with severe infection, if you do not develop memory later, you're good because you survived, right? So this is a joke. It doesn't really matter. I agree with you, but it will impact on the decision on whether you want to give a vaccine at a later stage or anything.
Okay.
I think obviously the whole area of resolution pharmacology is somewhat new. And one of the least studied areas has to do with memory and memory induction. It does change macrophage phenotype. It does change T cell. It changes more Th1 than Th2, but it does change them. It doesn't prevent cells from producing cytokines. But I don't have a good grasp on the role. In our systems, we measure T cell responses later. We measure antibody responses later. It doesn't change a lot, right? So you still have your levels of antibodies or your level of T cell, but very broad study, overall antibody response, overall interferon gamma production at a later stage, nothing in detail. I don't think this is something that anyone has looked in a lot of detail, to be honest.
Okay, thank you, Mauro.
Bruno.
Hi, Mauro. Really, really interesting stuff. It was really great to see all these molecules working kind of in the same way and protecting people and giving these new area of resolution pharmacology. But I was don't know if I missed something in the low dose influenza model followed by the staph infection. These animals supposedly they went through inflammation and resolution. So why are they more susceptible to the staph infection? What's going on in these the resolution phase of these animals? It's dependent on the original insults. It's just there is not enough of these resolution mediators being made, or it's because there are other mediators that are preventing and actually making it worse to fight the subsequent infection.
So it's streptococcus infection, just not staph.
Oh yeah, I'm sorry. Straps, not staph.
Staph is one of the few molecules there is no good data. Few bacteria there is no good data on. That's why But anyway, so as you infect an animal with influenza, there is a very, very marked decrease in the number of macrophages in the lung. Okay, it peaks at around day 3 to 7. The peak, not the valley. It decreased. Day 3 to 7 is the trough of macrophages, and then there is a repopulation of these lungs with macrophages, right? And they tend to get normal-ish by day 10, 14, 21. They are normal. Okay. Now, they are normal in numbers, but not in function, right? So what we've done in the past, but the experiment is different because we treated after infection. We treat just before pneumonia, right? What we can see is that the phenotype of macrophages is in such a way that you have better receptors for pneumococcal infection, for example, right? Such as the PAF receptor expression on macrophages or neutrophils, so it enters more easily, let's say. But what we have not done in detail is what are the changes, on the transcriptome level, right, or single cell level, of the macrophages exposed, of animals exposed early to angiotensin 127 at the trough and at a later stage. So this is ongoing, but I don't have the results. So I don't think it has to do with the amount of pro-resolving molecules late. Is the amount of pro-resolving molecules during infection that affects the kinetics and the phenotype of the macrophages. Was I able to answer your question? I cannot hear you, Bruno. Bruno, you mute, I think. Still mute. No.
Hello?
Oh, go ahead.
Yeah, good.
Okay. I don't know what happened here. But is it a matter of the infectious agents, or it's the timing of the reaction that is the problem?
Repeat that. I could.
Is it a matter with the infectious agents? It's something that is specific to the influenza virus, or it's just timing? Because supposedly, for natural selection purpose, these lung will have to recover, right, at some point.
Sure. And it takes a little bit of time, but 28, 2 months after, it's normal. Right. Bruno, I think it's been more studied by influenza because of the 1917 epidemic. But for sure, other infections do that. Beta coronavirus infection does that. Other chikungunya infection will change other places. So I think it's a characteristics of severe viral infections to change the milieu, the microenvironment of the organ it's affected, that will have long-term consequences. So as you return to homeostasis, depending how much you were affected, that homeostasis is different from the background, right? Yes. What I think the pro-resolving molecules do is to return that better and faster, whatever that means. Yeah.
All right. We do have questions on the chat.
Yeah, Felipe, I saw that. Yeah, I think for meningitis, I don't recall an experiment on meningitis. At least I don't recall now, but it should affect meningitis. It affects in other places, yeah. Oi, Luciana. Hi, good to see you. Angiotensin 127. I don't think it will have an impact on renal function for sure. In addition to, I don't think there is, the problem with people taking ACE inhibitors and undergoing sepsis is that you stop the administration of these drugs as soon as the patient is in the hospital, right? So you may lose that, that effectiveness or potential effective. I think the effects in the kidney is probably very relevant for angiotensin 127. For whatever reason, I think there are more receptors for angiotensin 127 in the kidney than other places. So you tend to see a more vivid dependence on the MAS receptor for the functions. Yeah.
Mauro, we still have one question here in the chat, and Marco has his hands raised. The first question was from Pamela. I think she's asking you if in your model, if you rather work with viruses or bacteria. I think both, right? It doesn't matter.
If I like, I don't like, the students like, and they want to have one that they like, yeah. I don't think I know how to work anymore. Anyway, I'm joking. It doesn't matter. You just have to have the infrastructure. It works. It doesn't matter.
And a readout, right? And a good readout to do it. Marco, do you wanna ask your question? Marco?
I think he wrote the druggability of
if I could, can I speak here?
Yeah, sure. Yeah.
Thank you. Hi, Mauro. Thank you very much for this brilliant talk. I was wondering if you could talk about a little bit about the druggability of this peptide. Since it is a peptide, in general, we have some problem to develop it as pharmaceutical. What do you think about this possibility?
Marco, is very druggable. So druggable that there are oral formulations that work extremely well, even in humans. The problem is the patents have worn out, right? The patents are gone. Now, and because at the time it was, these things were developed, they were thinking on hypertension. They did the studies on hypertension, it failed, right? So if you fail the trial, how do you sort it out? How do you revive something because you lose patent life or you don't have patent life? And a patent of use is much worse than a patent where you protect the molecule, the way you produced it and everything else. So this is what we are facing now. We are trying to revive the patents and the formulations, reformulate to make it better. Yeah. But it's not a problem of druggability. It's a problem of the patent, right? Because if you don't have a patent, you don't develop anything. Yeah. And this is an issue with the CB drugs as well. It could be the best thing of all, but if you don't have a patent, forget it. It doesn't move forward.
Yeah, in the patent in the right time. Otherwise,
yes, of course.
You lose the patent.
Which is always hard because we do work with the students. They have to defend their thesis and everything else.
Yeah.
An early, to patent early kills your strategy. It's very bad.
Yeah. It's a lesson.
Well, you have to make mistakes to move forward. Yeah, it's part of life.
Thank you.
See you, Marco.
See you.
Bruno, do you guys still have questions in Rio?
Oh, sorry, just forgot to lower the hand.
Okay, so Mauro, thank you very much. It was very good to hear you talk, and I mean a lot of questions. I think we for sure will call Pedro to talk here, and hope to see you again soon.
Fantastic. Nice seeing you, Thiago. Thank you, everyone. Pleasure to be here. Bye-bye.
Thank you very much.
Thank you, Mauro.
Bye-bye.
Thank you, Mauro. Great talk.
Thank you. Bye-bye.
Bye-bye. Thank you. Tchau, tchau. Até semana que vem.